All right, everyone. I know. All right, everyone. So welcome to Grand Rounds. If you want to follow along, you'll have to log on Zoom, which is the information here. So you can see the PowerPoint due to our AV issues. So next slide. So thank you everyone for, please mute your laptops if you can, please. Being attentive to the presenter, registering for the CME credit, and then completing and submitting a session eval. And that should be, the last slide will be a QR code. All right, so if you are seeing the slide, you'll see that the activity code for today to get credit. This is also on the Outlook invite that Kelsey sends out, so you can also look back on that if you need to. So I'll leave this up here for a bit for y'all. Everyone got it that needs it? Feel good? Okay. And this is just information regarding CME credit via text. And I think this is also on the Outlook invite that we send out, so all that info if you ever need it. All right, and this is just information regarding CME transcripts. So how to get those. And then just information regarding the AAFP credit system. Then here's the core competencies. It's happening. All right, so our conflict of interest statement. So Brian So has no financial relationships with ineligible companies to disclose. Now, Dr. Shi, do you want to do an intro for me?
It's my honor and privilege to introduce Dr. So, who many of you know him very well. He graduated the same year with me last year. And before that, he attended TCOM for medical school. And he just completed the sports medicine fellowship for the TIGMER program. Medicine getting accredited. And he will be starting his practice in Schertz, Texas, with the Health by Design. So we'll be seeing him around in San Antonio, taking care of our patients in this area. And we're excited to hear these lectures on wrist and ankle and hands, right? Common wrist and yes. And he's always been a great educator even when he was a resident. So we'll be expecting him to give a great presentation, and hopefully we'll see a lot of him with the workshops we are too. Thank you.
All right, so if you guys haven't already, if you could open up the slides, because I put a lot of pictures on there, so I think it'd be very helpful for you guys to follow. And like how Dr. Shi was saying, I was a former resident here. I was in her class and Dr. Mahdi's class, so 2019 to 2022. And then I did my TIGMER Sports Medicine Fellowship just now, so I just finished that. And yeah. One of the things, I'm severely jet lagged right now because I just got back from Korea. So it's like 2 a.m. over there. So if I say anything wrong or something doesn't sound right, feel free to just interrupt right away. Okay, cool. And if you can't follow along or you can't see my cursor, let me know too, because I might highlight some stuff on here. So today, I hope that everyone just has fun, really. I'm not here to bombard you with too much stuff, even though there is a lot of information on here. It's MSK. I know a lot of times we learn a lot of it in med school, but it kind of gets the back burner to a lot of other, higher morbidity, mortality stuff, so, and more important organs, right? So I understand why a lot of people would be uncomfortable with it. So I hope to just help you out here. If you guys want to input any comments or questions or anything, feel free to once again. So my objective, explain pathophysiology of common injuries. Secondly, outline management options and when to refer. And lastly, demonstrate common injections for the primary care physician. I know point 3 sounds really fun, but to be honest, we're not going to spend that much time on that. Today is mainly going to be on point 2. And the reason why is because, you know, as family medicine doctors, I'm sure if you haven't seen it already in your continuity clinics, you'll see something like, oh, someone got sent from the ER for a fractured wrist. Follow up a PCP in a week, and what do I do now, right? The referral is going to take like 3 months to go through. MRI is going to take forever. So what do I do from here during that meantime? And that's when everyone up to date's like crazy and stuff. Right? So my goal really is just to help you feel a little bit more comfortable once again. So hopefully you guys have a good time. It was a little bit stressful because I was in Korea when I was making these the PowerPoint, but I hope it makes sense to you guys. First case. 65-year-old left-handed male presenting to clinic for left wrist pain for many months. Doesn't recall any specific injury or trauma, believes he may have fallen around that time. He noticed his pain started worsening after starting a job as a janitor shortly thereafter. Describes the pain as dull, 4 out of 10, worsens with weather changes and activity. Pain improves with rest and over-the-counter NSAIDs. He locates the pain over his radial wrist. So physical exam. No swelling, ecchymosis, no overt deformity, neurovascularly intact, great pulses, equivocal snuff box tenderness, negative Finkelstein's, marked tenderness at the base of the thumb, a positive grind test, and full range of motion, so active and passive range of motion, but pinch grip actually hurt him. All right. Here's some x-rays. Now, when it comes to radiology and all of that, right, there's a saying, you know, one view is no view, right? So when you're trying to look for something, you want to get at least 2 views of it. I know an inpatient, we get 1 view chest x-rays all the time just to look for effusions and edema and stuff, but ideally it's 2 views, right? So here are 3 views of this patient's left hand. Anything stand out to you guys? You know, anything right off the bat that you guys can see? If not, it's totally fine too. What do you guys see? I see you two talking. What do you guys see? A little bit, okay, right? A little bit hyperextended. All right. Anything else? No fracture. Where are you seeing that? No, it's fine. Hey, feel free to be wrong. It's totally fine. I think you probably heard me talk about this too, but feel free to be wrong. We're all learning here. I don't know everything. Hamate? No. Okay. Okay. All right. So hold on to that thought. All right. Okay, cool. So we're thinking maybe an old fracture, maybe some alignment issues, something like that, right? So diagnosis. So from the history and from the x-ray that you guys saw, right? Oh, and the exam that was provided for you. What do you guys think happened? Okay, cool. So first carpal metacarpal osteoarthritis. It's also called CMCOA, right? And you know, oh, you guys can't go back the slides, right? I have to go back. Did you see it? Right? Okay. So I'll keep that in mind. All right. So first CMCOA, right? It's degeneration of the joint involving the thumb and the trapezium. So you see on the top right diagram or that picture, right? You see the metacarpal and the carpal metacarpal joint, right? So that's first metacarpal and the trapezium, right? So on the exam, you'd find a pain for a weak pinch as well as a positive grind test. Now, what is this grind test, right? So if you look at that top left picture, you see that he's put this, the provider is putting axial load. So they're trying to basically shorten that joint and then grind it back and forth, okay? You can kind of do this too, like that, push it in and then that. The idea is you're trying to make his osteoarthritis worse, right? You're trying to make that pain happen again. So that's the grind test. Conservative management includes activity modifications, relative rest. So you know that he recently started as a janitor about 6 months ago. Maybe he could change his grip, or maybe he can use his right hand more, or maybe he could request for like, you know, maybe lighter duty or something like that, right? Topical NSAIDs or anesthetics. So I'm a big fan of topical diclofenac or topical lidocaine, right? See if that helps out. And if they are using it and it doesn't help, make sure to ask them, are you using it 4 times a day the way that I prescribed it, right? So that's another thing. Oral NSAIDs or Tylenol, right? Steroid injections if you're comfortable doing it. One of the things I would recommend that if you do want to practice this stuff, do it now, right? Because it's, I mean, we all know it's better to do this in a supervised setting than just go blindly and do it on your own, right? So Steroid injections might be a good idea. Bracing is a thumb spica. So you see on that bottom picture over there, right? That's like a fancy looking thumb spica brace, right? I was trying not to put any brand names or anything because I'm not adding anything, but that's the basic idea, trying to support that joint, right? Other modalities, compression gloves, right? So they kind of look like biker gloves almost. They keep the joints warm, really. And paraffin wax. So I didn't know about this one. This is one that a pain management doctor I followed actually recommended for patients too. So put them in wax. Now, some of the other things you can do too is have them, make sure to tell them, put on the diclofenac gel before you put on the compression gloves, kind of enhance the medication or, yeah. Surgical management, let's say you tried everything, nothing helps, you have severe OA of that first CMC joint. You can send them to a hand surgeon to discuss options afterwards. Now, it's not up to you to know all the different options or anything, but just having a rough understanding would, be helpful whenever you counsel your patients. Arthroscopy would be cleaning out that joint. Osteotomy or trapeziectomy, so you either take out the carpal bone or you shave off the metacarpal, or arthrodesis, meaning fusion. Any questions so far? Cool. So when I think of MSK stuff, or joints or any of that stuff, there's really about 4 categories that I put them under. The first one would be joint degeneration or destruction. So the joint degeneration part would be the osteoarthritis, would be wear and tear, things like that. When you're looking at destruction, you're thinking of like autoimmune stuff like rheumatoid or lupus or something, or maybe a crystallopathy like gout or pseudogout, right? So basic anatomy. So let's go over this first. So I'm sure we've all seen this before. This diagram has typos, but the carpal bones, the wrist bones, there's a lot of them, right? And I know we've all memorized our own different mnemonic for it, right? But basically we're going through the proximal row and then the distal row. So the one that I first learned was so long to pinky. Here comes the thumb, right? And then some of the things to note is that the trapezium is under the thumb, right? The trapezoid is not. Another thing to note, because I was always confused about this until fellowship actually, is that the pisiform or the pisiform, that's a sesamoid bone. So it literally sits just on top of the triquetrum. It says triquetral like that, but it's triquetrum. So it sits on top of it like that. A sesamoid bone just means it's a floating bone stuck in like some kind of connective tissue. So think of the biggest sesamoid bone in your body being the patella, right? So it's kind of floating in there, right? So think of it like that. And then you have the metacarpals, the phalanxes, and proximally you have the radius and ulna. Anyone confused by this picture so far? No? All right, cool. I thought this was very helpful, actually. So the left side, you see just a normal wrist x-ray, and then the right side, it outlines the carpal bones, right? Keep in mind that the pisiform it's on the palmar side, right? So the pisiform would be more here, and then triquetrum is dorsally, right? And then the hamate, like how Jem was talking about, the hook of hamate, that's why it looks so funny over there. Just realize those are normal anatomy. Okay. Now, these are just some examples of degenerative, joint disease of the hand. I don't expect you guys to know Bouchard and Huberden nodes. I know we memorized it in med school. So for your interest or for your learning, right? Bouchard, since B is before H, you could think Bouchard nodes are more proximal to Huberden nodes. The point being is what we're actually looking at. So you see joint degeneration, right? Diffusely, but you see it in the PIP joints of both hands. And to describe further what I'm seeing is joint space narrowing. And then you see hyperlucency, right, of the cortical edges, meaning that there's joint degeneration and your body is trying to lay over more bone to help protect that joint. And so that's where you get the hyperlucency. You see osteophyte forming, right, on the sides, and then you see malalignment too. So in this sense, like the middle phalanx here, PIP joint here, right? You see it has more of an ulnar deviation. You might be able to appreciate on your exam, your physical exam. So that's Bouchard nodes, and then this is Huberden node. Once again, you see it on the DIP joints this time. I would say more pronounced in the second and third digits, the DIP joints of the right hand. But once again, joint space narrowing, osteophyte formation, and actually some malalignment too, some even as well at the distal phalanx of the second digits of both hands. You guys all see that? Yeah. I highly encourage you. I understand you guys aren't going to be doing only MSK stuff in your practice. But when you do order x-rays, I do encourage, take a look at it, right? And just get more familiar, because there will be a time when you will disagree with the radiologist. And it might take you a little bit longer for MSK stuff than me, because that's all I'm gonna look at. But it doesn't change the fact that, you should still look at what you're ordering so that you get comfortable with it, and you're double checking, right? Now, these are all just examples. You don't have to be pros in any of this stuff. This is scaphoid lunate advanced collapse. And so this is called a slack wrist, right? So in that diagram here, the ABC, that's just the stages of progression of the slack wrist. Once again, I just thought it was cool, really. But what it comes down to is this happens because of a foosh type of fall, a fall on outstretched hand, right? And then if you can see right here, between the scaphoid and lunate, we see a gap in there. So what happened was, at one point, this person probably fell, right? And then tore that scapholunate ligament. And what that happens is it results in an unstable wrist joint. And then you get the arthritis happening afterwards. So if you look at the x-ray on the right, you see, those arrows all pointing to different points of arthritis in the wrist joint. Why do we care about this? Because everybody has arthritis to one point or another, right? I'm sure some of us in here have it too. But some joints can't handle it more than others. And someone with a slack wrist like this, when it gets this severe, it's very debilitating, and it's your hand that you're losing or your wrist that you're losing. So, it is definitely something that, that you got to respect, right? So I think this one's a cool thing to just know about. Here's another one, a snack wrist. So a scaphoid non-union advanced collapse. And so this one, how in med school and even in residency, we learn about a scaphoid fracture and why do you care so much, right? This is why you care so much. So I don't think anyone ever told me about a snack wrist until I had to look it up myself, actually. But the point is this is a consequence of a scaphoid fracture that either presented to you really late or was poorly managed or improperly managed or something along the lines there, right? And so what you have is you just have a mess of this scaphoid on the x-ray that you see there, but then you have subsequent arthritis happening because of it, right? And so what could have been like, either proper conservative management or maybe even a screw fixation, now you're talking about possibly like a proximal row carpectomy where you're taking out wrist bones left and right, to help salvage this joint. So this is why you care about scaphoid fractures and things like that, right? Questions so far? Yeah. All right, let's move on to case 2. All right, 55, yes.
How often are those two slack or snap wrists occurring?
That's a good question. I'm not sure. What we'll see is, if you have a fall, of that mechanism and something happened, it won't show until what 40, 50 years down the road, right? For example, in my continuity clinic, there was a patient, as a new patient visit, she was like, both my wrists hurt. And I was like, what happened? And she can't tell me, right? And so we get x-rays and it was slack wrists both, and they were just severe. I mean, I couldn't blame her. And so she went straight to the hand surgeon. But yeah, sorry, I can't tell you what that. All right, case 2, 55-year-old right-hand dominant female presents to clinic with right wrist pain. Status post-fall 7 days ago. She was seen at the local ER, describes the fall as a foosh mechanism. After she tripped on the sidewalk, she was diagnosed with a wrist sprain because the x-rays were negative and was discharged with a thumb spica splint and a prescription for tramadol. She was told to follow up with a PCP in 1 week. She's saying her wrist pain has not improved. She's been taking out the splint because it interferes with her work as a waitress, and she can't afford any time off. She doesn't have her splint on when she's seeing you today, and she needs a refill of her tramadol. So her exam, she's got some swelling maybe of the dorsum of the wrist, painful active and passive range of motion of the wrist, good strength. But in the parentheses, when I said, although pain reproduced radially, I meant radial deviation. So reproduced her pain, and then positive stuff box tenderness. Here are x-rays to view. Jem, what do you see? Oh, dang it, I thought you said Scaphoid. Yeah, there you go. Yeah, that's what I see too, right? And when we're looking here, we see over here, this hypolucency, this line right here in the middle, right? I think it's a little bit harder to see over here, right? I personally can't see it, but point being is, I agree with you, right? Diagnosis, we just talked about this, right? And before we talked about the diagnosis, I thought this was actually a pretty cool lateral X-ray, just breaking down the outlines of the carpal bones. Now, just keep in mind, for this one, it's showing a triquetral fracture, and that's not the case. So please don't, yeah, this isn't the case. But you know, the outlines I thought would be really helpful. So hopefully this helps you guys out. The purpose of these slides when I was making them was meant to be more of a reference than learning it all now. So hopefully it helps you out down the line. Okay, non-displaced scaphoid fracture. So 90% of the fractures occur at the waist, which heals pretty well. So if you look at the upper picture, you see 3 different types of fractures, or 3 locations of fractures: the distal fracture, the waist, and the proximal fracture. And then we learned for the scaphoid during medical school that what makes it so special. Yeah, I mean, why? Why does it get avian? Do you remember? The retrograde blood supply, right? So if most bones get their blood supply proximal to distal, this one's distal to proximal. So between these 3, which one do you think has the worst case of healing? The distal, waist, or proximal? Proximal, right? I think so too. So high risk factors, delayed immobilization, meaning nothing was done for it for greater than 4 weeks after the injury. Greater than 1 millimeter separation, proximal pulse or proximal fracture, a vertical or oblique pattern. So that any of those things would make you more concerned that, hey, this fracture might not heal very well, right? X-ray views, you want to get PA, lat, oblique, and then the scaphoid view. So you want 30 degrees wrist extension and 20 degrees ulnar deviation, right? So that helps identify the scaphoid a little bit better. Okay, that scaphoid view, all right? Conservative management would be a thumb spica cast, minimum 8 weeks, or if you see X-ray evidence of routine healing. So what that means, and the reason why I'm going so in depth with this is because you'll see this in your clinic, and they might not get the referral to sport to ortho before, you know, like within that same week or something. So you're going to have to manage this for a couple of weeks, right? So that's why I think this is important. What is X-ray evidence of routine healing? It's called a hard callus formation. So basically what you see is a bump. You see bumps on the side of the fracture, and that lets you know that your body is laying down bone to help fill in that fracture, basically. And then what will happen over the next like 9 to 12 months is your body will resorb parts of it and make it look nice and pretty. So you tell your patients that X-rays won't look pretty for a year, right? But as long as you see that hard callus, you know that routine healing is happening, okay? Early range of motion is super important the moment they get out of the brace, right? Because that's the first thing you lose is your range of motion. You get a lot of stiffness and all of that. And let them know it might take 8 to 12 weeks for healing to actually happen. All right. So some of the things, some of the nuances I didn't put in here, but you know, at least you hear it right now, is you don't have to put them in a thumb spica cast, see you in 8 weeks, right? You can see them in the meantime. You can see them in 2 to 3 weeks, make sure that healing is happening or nothing is getting worse, right? You can have that cast taken off and recast it at that visit. You can get X-rays at that visit. Now, I know we don't have on-site X-rays here, right? But maybe you could take off the cast, send them downstairs to get an X-ray, and then have them come back up or something like that. I know that'll take a while, but that's one of the things you can do in the family clinic. But the point is, you know, you can see them in the interim, and you can get repeat X-rays. That's okay, all right? Surgical management, you refer to ortho hand plastics. If you're worried about non-union, high risk fractures, you know, things like that. Any questions about this one? Cool. Yes.
Timing of that, I guess, in between follow-ups, for sure, I think.
So, you know, so I know the board question, right? The board answer is you're suspecting a scaphoid injury, right? Then you splint them and then you have repeat X-rays in 2 weeks. Sure, you can do that. So getting repeat X-rays 2 weeks out and then another 6 weeks out, you know, would be a good idea. If it's like for some reason like a high caliber athlete or someone who, who is like a professional, it's like a professional concern, for example, like a police officer or firefighter or something, then, you might want to go just straight to a CT. So keep in mind that a CT would be the best modality if you're concerned about a fracture and you need answers quick, right? Not an MRI. The CT gives you the 3D planning of this fracture, and it tells the surgeon, or the surgeon can plan around it to, best address the issue. Okay. Cool. Does that answer your question? Anything else?
So, if it takes a while for a patient to see by a specialist, sport therapist, so it would be like us doing the casting.
Hopefully you have a tech that can do it.
It would be like that. Like,
Yeah. Yeah. Also, let's say it takes forever. Let's say it takes like 3 months for, the patient to get seen by sports medicine, right? You're not going to have them in a cast for 3 months. That is negligent, or I won't say that, but that is bad for the patient, right? Because they're going to lose their range of motion and all of that. So the things that you're going to look for is when you can get them out of the cast is when you have that cast gone or the splint gone or something. First of all, just check for tenderness, right? If they're non-tender, then you're thinking, hey, I'm thinking this is healing well, right? So they're non-tender, and then hopefully you'll get x-rays and show evidence of that hard callus, right? And then you can do other things too, and I'll talk about that later on in the slides, but you can do things like test their protective strength, right? So I'm in the sports world, right? So if I had a football player who, needs their wrist or alignment or something, right? I would have them do up downs, or I'd have them do push-ups and stuff. If they can do that just fine, go on your way, do your physical therapy, get that range of motion, get better, and go play, right? So that's, of course, you guys aren't going to do that far, but that would be the first thing that you're looking for. Tenderness, and that snuff box tenderness, good range of motion, like painless range of motion, and then protective strength. Cool. Anything else? All right. So this is the second category when I think of MSK injuries is trauma, or you can think fractures or tears, like tendon tears, things like that. All right. So general rule of thumb, fractures take about 6 to 8 weeks to form that hard callus, meaning for that routine healing. 6 to 8 weeks. If you don't live, they're like, how long is this going to take? 6 to 8 weeks. Just say that, right? Some fractures take a lot longer. Some fractures, and especially if they're younger, it might take 4 to 6. Never know. But the rule of thumb, 6 to 8. Okay. Repeat x-rays are obtained in the interim for evidence of this hard callus, which is indicative of routine healing, right? So that's, the diagnoses when it says blah, 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 blah with routine healing. That's, that's how you prove the x-ray and things like that, okay? Now, the ultimate question that I ask myself whenever I see a patient with an injury, right? Especially an acute injury, is the joint or whatever's going on, is it stable or unstable? So in the setting of a fracture, is it stable or unstable? And the way I define that, stable meaning that if I just left it alone, or if I kind of guided it with like a splint or something and let it heal, will they get function about almost to the same as before that fracture, right? Without any surgical intervention. That's what I think of when I think stable. And then unstable is like, ooh, this guy needs help. This guy needs surgery or something, right? And if you don't know, refer to a specialist, because sometimes what you think might be an unstable fracture or unstable injury could actually be managed conservatively. But those are the little nuances that specialists get paid for. Okay? So, but that's how I think of injuries, stable or unstable. And then once again, how to test stability, exam maneuvers, right? Painful arc of motion. So, have them move around if that hurts, or if it's severely limited because of pain, or even a mechanical block, for example, like an elbow, they literally can't flex and extend because there's something blocking their elbow. Like, ooh, I think you need surgery, right? Protective strength. Okay. This, you guys, I just thought it was a cool diagram. Refer to it. We're not going to go through all this stuff. One of the things I thought was cool was the capitate also has a retrograde blood supply. I didn't know that. I didn't know that till sports fellowship, actually. So I think this is a good one to just refer back to, right? Boxers fractures. You guys are going to see this too, right? Because we all go to JDC. So remember, 2 views, right? So we see here, you see the neck of the fifth metacarpal, right? You see that there's some volar angulation of it, and on the lateral view, you can see that again, that volar angulation, right? Why do you care? Because if it's at a certain degree or more so, then it's it might need surgery. And if it isn't, then you just leave it alone. So knowing this nuance, I think is important for the family medicine doctor. And then I showed some splints here. The ulnar gutter, right, is the one that you would do. Just keep in mind, there's some wrist extension and about 60 to 90 degrees of metacarpal MCP flexion when you do that, okay? The ulnar gutter. All right, so a boxer fracture, alignment. I know Dr. Nato talks about this a lot, about the scissoring, right? When you say check the alignment, he says check for the scissoring. The reason why is because if you see scissoring on someone that you think has a boxer's fracture, that means that fracture rotated, and that is not a good sign, right? And so what you want to make sure is, as you see here, that everything points to, I used to think of it as a distal radius, but whatever. They all point to that same point over here, right? And if they don't, then you're concerned about something. Other things that you might see is an absence of a knuckle. So if you see all four here, and then one is literally gone because that metacarpal neck, right, is actually volarly displaced, so that knuckle's gone. So that's another thing on your exam finding. Painful arc of motion, right? Lateral view here, and then a high risk factor, especially for the fifth and fourth metacarpals, is if it's angulated more than 50 degrees, that's when you're like, I think this needs surgery, or at least a hand surgeon to sign off on this, right? So for your JDC kids, that's what you look for. You want two views, remember, okay? You want that lateral view. If you're like, hey, I think this can be managed conservatively, only got a splint times 4 weeks, but get the repeat x-rays to get that, to show that hard callus once again. Early range motion, they probably won't get PT or OT, right? So you kind of have to test it yourself, test their strength, have them do push-ups, don't have them punch walls, right, or people. And then hopefully, they can go on their way and be successful, right? Can clear once you have pain-free arc of motion and good protective strength. I'm emphasizing a lot of the same points over and over, but you'd be surprised, like when you're actually managing it, like you forget about a couple of things, like, oh, I should have had this in the past, maybe 2 more weeks, or, surgical management, screw fixation. Distal radial fractures, this one, these are actually, so I thought it'd be helpful to know. On the left side, you see that this is a pediatric patient because growth plates are open and that looks like an alien wrist, right? But you see, at those yellow arrows, you see a buckle fracture. So if you look at the cortex, you see it just buckles out like that. It's not a congruent, like consistent straight line, that cortex. And so that's how you know that this is a buckle or torus fracture. Honestly, probably won't need surgery for it. You just put him in a radial gutter, or thumb spica, or maybe even a volar splint, or and then have them come back in 4 to 6 weeks or something. Get that interim. I don't even think you need an interim X-ray for this, because there's really nothing you're concerned about. Really, it heals well on its own. And then the Colles and Smith fractures here. One's a Fuchs and one's a, I don't know what you call this, but you fall on a flexed wrist, right? So I don't know if you have to know the difference between the two, but that's what it is. Question so far? Cool. Differentials for a distal radial fracture, maybe Salter-Harris if the growth plates are open. Monteggia or Galeazzi fractures or dislocation. You don't have to know those, but just know that, like, sometimes with a fracture, you can get an associated dislocation as well. So don't just, if you're worried about the wrist and you're like, ooh, I think there's something else going on at the elbow too, get an X-ray of the elbow. Why not? Check the range of motion of the elbow too, because sometimes that can happen. Once again, here are just some guidelines, right? Refer back to it. I hope it helps you out. One of the things, surgical referral, if any concern about displacement, articular involvement, or multiple fractures. Articular, so that means when you're looking at a joint, let's say like a big joint, like a knee, right? And then there's a fracture that extends into that joint space, that makes it a higher risk fracture. So if you see that, that's concerning. Okay, that's not necessarily surgery, but it's concerning. And then multiple fractures, I'm sure we've all heard of like compound fractures before. The term now is comminuted. So if you hear comminuted, that means there's multiple fractures happening. Okay. All right. Case 3. How are we doing on time? 40-year-old left-handed male is presenting to your clinic with 1 year progressively worsening weakness of his left hand. He's a carpenter and has noted he has been busier than usual this past year. Does not identify any trauma or other inciting factors. He was concerned because he has had progressively worsening grip strength at work and has had to take the last week off due to safety concerns. He denies any numbness and tingling. Physical exam, atrophy to the hypothenar eminence, positive Frohman sign, 3 out of 5 strength of finger abduction, abduction, and adduction. Equivocal Tinel sign of the wrist, negative Tinels at the elbow, negative Sperling's test. Right? So just so that we're on the same page, Tinel is basically, you know, right, to check for that for carpal tunnel. You can do Tinels anywhere. So Tinel here, over here, like at the elbow, or anywhere nerve travel really. So when you Tinel sign, you got to specify where you're doing it, right? Sperling's test is check the neck, right? So it's a provocative maneuver. Here's an X-ray. I wasn't trying to be tricky. These are literally the same X-rays from the first case. So the point is, we don't see much there. Maybe some CMC arthritis. That's about it. Okay. Diagnosis. What do you guys think is going on from the exam and the unremarkable X-ray? That's fair. Dude, I actually didn't put that in my differential, but nice. What else? Ulnar nerve entrapment. Nice. I agree. But all right, what else? I know Dr. Tershani always says, if it's not the 3.5, then you lost your diagnosis, right? So just know that it can be a little bit more complicated than that. Right? Well, let's do this. Ulnar tunnel syndrome. So ulnar nerve entrapment, right? So compression of the ulnar nerve traveling through Guyon's canal, which is superficial to the carpal tunnel. So if you look at that top right diagram, it's a transverse cross section. So you see that big pocket with the median nerve there, that's the carpal tunnel. And then at the bottom right of that, that is Guyon's canal, right? So it's superficial to the carpal tunnel. And that has a neurovascular bundle of the ulnar artery and the ulnar nerve, right? So that's what's getting compressed, or maybe at this point, right? It can occur in 3 locations: proximal to the bifurcation, distally to deep branch, or distally to superficial sensory branch. So if you look at numbers 1, 2, and 3 on that left side, you know, 1 would be proximal to the bifurcation, 2 would be, that's distally to the deep motor branch, and then 3 would be distally to the superficial sensory branch. Point being is that, let's say you only knock out number 3 over there, right? Then you get paresthesias, right? If you only knock out number 2, you don't get paresthesias, but you get motor weakness. And if you knock out number 1, you get everything, paresthesias and motor weakness. So just because you don't have paresthesias doesn't mean you don't have a nerve issue, because this guy clearly has other signs, right? And then if it gets knocked out proximal to 0.1, right, or number 1, then you can actually get other things like paresthesias to the proximal palmar aspect, which isn't seen in Guyon's canal entrapment, right? So the point is, and I'll talk about on the next slide, is there's a lot of different points that this nerve can be entrapped, and that goes for any nerve really. Differential, cubital tunnel syndrome, so at the elbow, cervical radiculopathy or myelopathy, carpal tunnel, ulnar artery thrombosis, thoracic outlet. So there's a wide range of things. We just keep tracking it approximately to the spine, right? Some of the exam signs I was talking about, right? The Frohman sign on the bottom right, what that's testing is you have the abductor pollicis longus. So this muscle right here, that makes you do this, abduct your thumb, right? So the way that you would test it is you give someone a piece of paper, can't ball that. You give someone a piece of paper, right? And you'd be like, hey, can you pinch it like this with your thumb straight? And then you have them pull. And if they can do this, that's a negative Frohman sign, right? But because if they have ulnar nerve entrapment or, you know, and their motor branch isn't working, they try to compensate for this by flexing their thumb at the IP joint. And that's now median nerve right there, right? So this would be a positive Frohman sign because they can't do this, so they compensate by doing this. And that's a different nerve now. So a positive Frohman sign. Wartenberg sign over here, and there's Wartenberg's disease and all, there's a bunch of Wartenberg sign. Wartenberg sign is when you have the AD duct and that pinky still stays out there, right? So that's where you're like, ooh, I think this is ulnar nerve. Okay. Are you guys doing all right so far? Yeah, I think this is fun. I think this is interesting. So I'm like geeking out about this stuff. But I hope you guys are interested too. Now, the point is, how do you manage this? EMG it, right? Even if you think, hey, I think I know what's going on, because you might not know where the lesion actually is, right? And that might help, you know, the subsequent surgeon if you're going to refer out. So EMG. And then considering the extent of muscle atrophy in this case, it probably was going on for a long time. I would have sent this guy to a surgeon, hand surgeon. Right? If you want to do conservative management, splinting, NSAIDs, activity modification, right? Maybe some PTOT, something like that. Maybe they can do stuff like nerve gliding or something else. Okay. So the third category, neurovascular, right? So the first two we talked about joint degeneration, trauma, and now neurovascular. Right. Carpal tunnel, we see this all the time. Dr. Prasine, we just talked about you right before you came in, right? But even if you think it's carpal tunnel, still get the EMG, right? Because it can still elucidate a lot of stuff for you. Because maybe it's not carpal tunnel. Maybe it's something else like pronator Terry syndrome that looks just like carpal tunnel, right? Except that 10 Ls here would be negative and it'd be positive over here approximately. So you never know. Or maybe it's coming from the neck. So get EMG is a good idea. Conservative management for a carpal tunnel would be a splint, a cock-up wrist splint, the ones they would do at night. NSAIDs, activity modifications, the corticosteroid injection, CSI, right? That's definitely something that, you know, you guys, I think if you're interested in doing it, start doing it, like practicing on patients. If they're needing it every 3 months on the dot, then that's when you're like, I think you might need to go see a surgeon. You might need that carpal tunnel release. Another thing to note too is once you become proficient at these injections, it can tell you a lot, because if you actually get a lot of relief from steroid injections, that actually is a good indicator that surgery will do well for you. And if you do an injection and you place it correctly and all of that, and you don't get much relief, that actually might mean that the surgery might not do very well for them either. So that steroid injection tells a lot. And that's why hand surgeons, even after you've done so many, and then they refer you to the hand surgeon, they'll do their own, right? Because they want to make sure. So those are important things to know. Surgical management, decompression, but yeah. Any questions here? Yeah. I attached a video for carpal tunnel, by the way, so I think that'll be very helpful. Other things on the differential, cervical radiculopathy. We're not going to go into this, but dermatomes, myotomes, and what a herniated disc looks like, right? All right, last case. 35-year-old right-handed female presents to the clinic with worsening right wrist pain for 3 months. She's a first-time mother who recently delivered 3 months ago. She stated that the pregnancy was difficult due to gestational diabetes, as well as complications due to shoulder dystocia. She notices the pain every time she picks up her son and has tried over-the-counter Tylenol with minimal relief. Physical exam, increased warmth and swelling to the dorsum of the right wrist, positive Finkelstein, full range of motion, however, pain with ulnar deviation. X-rays, I hope you guys don't see anything there, because I don't see anything there either. Okay. What do you guys think is going on? The Quervain's tendonitis, right? The point I was trying to make in this case was this is a heavy baby, basically, you know, and you know, mom's picking up this baby all the time and it's really heavy. So yeah. So de Quervain's tendonitis, it's an overuse injury due to repetitive ulnar deviation. So if you're picking up the baby like this, or if you're like this, right? You're doing this all the time. So differentials, it can be intersection syndrome, first CMC OA, scaphoid fracture, or AVN, scaphoid lunate. So it could be other things. Conservative management, rest, oral NSAIDs or oral corticosteroids if they're not diabetic, if they're not, right? They don't have any kidneys are fine. Steroid injection and bracing, right? So here's another thumb spica brace, right, to help protect from the abduction, right? And extension. Surgery is rarely needed. However, if you guys think this is de Quervain's and then they're not getting any better with everything you're throwing at them, right? And it's going on for months and months, you might want to get that MRI, right? Because you might be missing like a mass that's impinging on, maybe those a tendon tear that we didn't know about or something, right? And considering how long MRIs take in our clinic, right? You might actually want to get it done a little bit earlier, like maybe if they're not better after 2 to 3 months, then go ahead and get that MRI. And then at 6 months out, you'll get the MRI. So that's one of the things to consider too. Just realize in private practice, it's a lot easier to get MRIs and referrals and all of that. It's much easier. Okay, so the last category I have is soft tissue or overuse injury. So tendonitis, tendinosynovitis, things like that, all those itises, right? So tendonitis or tendinosynovitis, you can differentiate from more serious injuries like scaphoid fractures from the history, from the lack of inciting factors, no trauma, anything like that. And this second part, this clinical pearl, it's kind of confusing. So let me show you guys. But one of my attendings during fellowship would actually help me understand just from your exam. Hey, I think this is an overuse tendinosynovitis rather than anything else, because I kept thinking everything was a fracture at first. You can reproduce the pain through passive stretch or active resisted eccentric contraction. Okay, so let's say we're talking about the extensors of the wrist, right? So the extensors right here. So if I want to actively contract it, then I do that. That's short of it, right? Passively stretching it would mean me as a provider doing this. So I'm passively stretching the extensor, right? That can cause pain. But then another thing is active resisted eccentric. So what are eccentrics? Those are negatives, right? So for anyone who works out, right? Let's say you're doing a push-up. So you're pushing, right? So that's the contraction. And then the negative is when the muscle elongates, right? So elongates. So this is the negative part. So for a pull-up, the contraction, and then the negative is lengthening back that muscle. So if you think of it right here, right? This would lengthen the muscle, right? So what you do is you resist them and you're doing this while they're you're lengthening that muscle. Yeah, the portrait is kind of blinking right now. But yeah, there's a lot of things I didn't mention. So this wasn't meant to be comprehensive. This was actually supposed to be more of like just relevant to your practice or future practice. Yeah, because everyone knows split the distal radius fracture, right? You know it, but it's like, oh, what do I do 2 weeks out or 4 weeks out? Or 6. So that part's hard. Scaphoid fracture. Oh yeah, splinted an X-ray in 2 weeks, and then what? Like, so anything else? I'm in town. Oh, these are my records. I'm in town There's a handful of people who have my number and my contact information, so if you have questions, feel free to reach out to me. I'm more than happy to help out. My clinic actually is